frequently than the Olympics. And compared to that, I would characterize it as a little brainier, and if you don't count caffeine, there's a lot less doping. So this morning, our plan is to, first of all, give you a lot of data, because that's what the health assessment is about. It's a deep dive into the health of our community. We're going to say a few remarks to help you process what we think some of the key messages are. And at the end, we'll have time for questions and discussion. And because it's the Bexar County Health Assessment, and to get us off to a proper start, we've invited the Chief Executive of Bexar County, the Honorable Judge Nelson Wolff, to get us off to a good start. And he just walked in and sat down, so the timing is perfect. Judge Wolff, I'll welcome you to the podium.
Well, first of all, let me thank you for your continuing support of the collaborative and the work that y'all have been doing over the last few years as we try to get a better handle on delivering health care to our citizens in the Bexar County area, as well as trying to encourage people to take a little bit better care of themselves. So much of it does relate to the ability of someone to take that little extra step to eat better and do a little exercising. Now, we know that can be challenging from time to time, and we know things are presented in various places where you might go to purchase food or to go out and eat somewhere, that many times unknowingly you're consuming a lot of totally worthless calories. And we know that we've tried to do on many different occasions to get the federal government, to get grocery stores, restaurants to better label what is you're eating and what are the consequences of the food that you're taking. So a good deal of it is not enough information is being presented to people when they do to consume whether it's food or drinks. And I want to thank all of you that have worked with us on the effort to get over to the citizens what the sugar content of drinks are. I think we're beginning to have some impact on that. We had a lot of resistance when we started the campaign. As you know, the City Council turned it down, so the Commissioner's Court picked it up, and we've got a good program going. Most people not understanding that they took a 20-ounce bottle of Coca-Cola, they were swallowing 16 packs of sugar. So more and more information that we can give out in terms of encouraging people to take better care of themselves and to exercise along with what they eat. So that still has to, I think, to be right at the top level of what we would encourage people to do. We simply can't take care and don't have the resources to meet the needs of people that don't take care of themselves. And so we've got to encourage more of that as we go along. We know that there's a great disparity within our community between those that do have resources and those that do not. And I think that this report that has come out this year probably shows that in a more direct way maybe than what other reports have shown. And the fact that we have almost a 20-year differentiation in life expectancy between people living in the south and north of the county due to the disparities of access to health care and all the other education components that are needed to try to help someone. That's a huge disparity. I had no idea that it was that big. And we know we still have a number of people that we've never been able to pull up the ladder to pull them out of poverty. We still have something in the neighborhood of some 18% of that. And we still have, unfortunately, 70% of adults that are overweight are obese. And I believe that's still the greatest indicator of an unhealthy life and a relatively short life. Now, all of us are a little bit overweight than what we should be, but we do have a number of people that are way beyond the weight limits that they should experience. And so we've got to continue to try to work on that issue. We also know that the state of Texas, if not the worst, certainly like next to the worst in the nation in terms of health care for citizens. We hear the legislature talking about in the next session to even make the resources of local government less than what we have today, and at the same time cutting back on services that they provide. The deaf ears, the unwillingness, the hard-headedness, the political issues that we see in the legislature today are refusing to expand Medicaid across the state has a devastating impact on the health care of people. There's only so much we can do in a local community with the resources that we have, whether it's Bexar County's hospital district, doing business at University Hospital, or whether it's the Center for Healthcare Services. We're also having to look at challenges that are faced with some of the programs that will possibly change in the future as Texas continues to hold out and refuses to expand Medicaid or to develop a program of themselves. I don't know how we crack that. I don't know how much more or what we need to do to bring that attention to the state of Texas. It's an economic issue. Some of the leadership may not care about what happens to poor people. They may put restrictions on what a woman may do with her body, but then they don't want to take the responsibility to help that woman take care of their child and to provide the health care that's necessary for it. I must encourage you, if we're ever going to do better in the state of Texas, that you simply got to get the ear of the legislature. You've got to become more politically active. Choose whatever you want to do. There's some great Republicans, great Democrats, but you better start working hard or we will never serve our health care needs without a tremendous change in the attitude of the state of Texas. So again, I want to thank you for the work you're doing. I believe Bexar County is way ahead of many other communities, and certainly what we're doing in the criminal justice system, certainly what we're doing in some of our mental health initiatives. But again, there is a limit to resources. Until the state steps up and accepts Medicaid, we're going to continue to face significant challenges in our community and across the state. So get over there, grab some of these legislators by the ears and shake their heads and say, let's get with it and let's help the people of the state of Texas instead of harming the people of Texas. Thank you.
Well, thank you, Judge, for getting us off to a great start, framing the issues, I would say in a very candid and vigorous way, which is something that we definitely need to do, because ultimately the report is full of data on which we base our decisions and our policies, but the next step is being vigorous in our pursuit of policies that will actually improve the lot of the people in our community. So thanks again to Judge Wolf for doing that this morning. So my next task is briefly to say thank you to the people who make this possible, the partners who fund the health assessment. That includes the Kronkowski Foundation, Methodist Healthcare Ministries, Allegis, and of course our folks at Bexar County who provide support for the collaborative. All right, so before we take a deep dive into the data, we wanted this morning to actually start with something vivid. I'm a data person, and I'm going to start with some voices from the community to help us really hear some stories and personal accounts of the struggles that are going on every day that lie underneath the statistics that you're going to see in a few minutes. So for that, I'm going to introduce Elizabeth Lutz, and she's going to kick off that next segment of our program. Liz?
Well, good morning, everyone. Thank you so much for being with us today. If you haven't already had your coffee, please do have some coffee. We are just delighted again to have you guys, and I want to ask Mercedes Bristol and Delia Martinez to make their way up. I'm very excited about this part of the agenda today because it really is, we're going to be sharing some information today, and really it encompasses why we do the needs assessment and why we've come together as partners today. So through this process, many of you know that we not only collect data and work with many partners to be able to understand health, we do an extensive amount of work to include the community voice. This year, we had 17 key informant interviews that included leadership like County Judge Nelson Wolf, hospital leadership, and some other stakeholders that are really driving some of the priorities through Bexar County. But at the same time, we know that that's only half the story, and that we really need to start talking more with those families that are in need, that are doing things on their own and pushing through. And so through this process, we were able to have a conversation with a group called Grandparents Raising Grandchildren. And this is not necessarily a new phenomenon that just started happening 2 years ago or 3 years ago. But in our community, this is something that culturally has happened through the course of so many different decades. It's an emerging issue for us to start recognizing, because oftentimes when we think about our older population and serving our older population, we have a missed opportunity to really understand how that community is really changing and is really threatened by a lot of other things that are happening with them. So I'm just going to give you a brief history of this group. This group was actually formed formally through an awareness that started from a grant called Making Connections back in 2007, and it was through La Fe Policy Education and Research Center. They developed the Abuelos y Nietos Juntos program that was led by Dr. Yolanda Santos and Juan Flores. And then thereafter, the program evolved into support groups that were concerned about grandmothers. And basically, these grandmothers were making some decisions, and I'll kind of say grandmothers and grandfathers. And they were making some tough decisions, because one of the things that was happening is not only were they going through their own serious issues, whether it be health conditions or poverty or a strict limited income, but they found themselves becoming the caretakers for their grandchildren suddenly because of different things that were happening. Many of this is triggered by drug abuse, substance abuse, domestic violence, and the grandparents really were stepping up to the plate to figure out, how is it that I can protect my grandchildren? How do I ensure that I'm doing the best that I can? At the same time, looking at the realities and thinking, I have limited resources, I don't have any help, and a lot of the policies that are in place right now are not suited to fit or to help me. But it's easy for me to go and ask for help for my own personal housing. It's easy for me to probably go and request help for my own personal feeding program. But when I all of a sudden become the caretaker of 3 or 4 little ones, who's going to help me with beds? Who's going to help me with clothing? Who's going to help me with finances that I need in order to all of a sudden become this parent to this child? So today I'm going to pass information over to, I'm going to introduce you to both of these advocates who have just done a tremendous amount of work in our community. And I will tell you that where they started in the roots formally in 2007 and where they are now, they are now the support group that offers 2 support areas. They operate under the umbrella of the YWCA. But I can tell you that their efforts are far more than just 2 support groups. They're in the community, they're meeting families, and they are really centered and surrounded by not just 2 grandparents, not just 3 grandparents, But by far, this focus group was the largest that we had. We had over 23 grandparents that came to the meeting, and still there were more that wanted to come and couldn't get there because of transportation or other obligations that they had with their grandchildren. So I'm going to pass this information over. I'm going to pass the mic over to our two advocates, and I encourage you to listen to their story, open up your hearts, and share their message with others.
Well, where do we start? What's the first thought that you have when you hear the word grandmother or grandparent? Someone you visit on weekends or maybe spend a few weeks in the summer? Someone who takes you out for ice cream, spoils you, listens to your stories, reads you books, gives you gifts that are handmade and crafted by your love? Those are some of the thoughts that come to my mind when I was thinking, what do I think about my grandmother? Someone who treats their grandchildren with more relaxed or permissive manners than they ever treated their own children. As a result, grandchildren often feel more comfortable discussing sensitive issues with the grandparents than with their own parents. Well, that story changed when 5 years ago, CPS brought me 5 grandchildren. The baby was 3 months old, and the oldest one was 9 years old. And they had a CPS case. And I was fighting CPS because this was their 3rd removal, and they wanted to place the children back with the mother. My son wasn't around at the time either. And so I had to hire an attorney to do an intervention. So these children would not go back into living in motels or hotels or wherever mother had taken them. They all had emotional issues. They had all been scarred by either drugs or abuse. My grandson at the 2nd grade, they had to evacuate the 2nd grade classroom because he had a meltdown. I didn't know what that meant. I didn't know what he was doing. I thought he was being rebellious. I thought he was angry because what happened. But I didn't know he had post-traumatic stress disorder. I didn't know he had ADHD. So with the help of our doctors, they were diagnosed. Well, he was diagnosed. He now is in a band. He's now playing an instrument. He's now being more productive. The 9-year-old was the parent of these other children. His mom wasn't around physically or mentally. And so she took on being the parent. When I took her in and to raise her, she continued to be the parent, and she challenged me all the time, trying to correct me on how I was parenting the children. So this, she's now also, I didn't know she was suffering from depression, and so her too had to get some medication. I had a 3-year-old wearing 18 months clothes. She was suffering from failure to drive. I didn't know she had a speech impediment. She couldn't speak. We've had her in therapy now, speech therapy for 4 years. And now they say she might have a little cleft palate. So we're searching those answers for her so she can be able to function properly in life. At the age of 57, I was forced to take an early retirement. I used to work with Health and Human Services and provide benefits for other parents and grandparents. It's sad that I didn't have a place to put these children when I took them all in. I didn't have beds for them. I wasn't prepared. So I went and applied for the $1,000 grandparent grant. I was denied because my car was paid off. So these children had to sleep on blankets until I was able to help and give them what they needed. I'm a single grandmother, so I don't have a whole lot of support. I don't have a lot of family. We came from California here 12 years ago. So I don't know a whole lot of people that I could have reached out to at that time. A few months ago, my 14-year-old granddaughter asked me, "Why do you treat the other grandchildren different from us?" My answer was, "I'm not raising those children. I'm raising you fine. Now I'm your parent, I'm not your grandmother." One of the biggest fears that my grandkids have is what is going to happen to us if we die, Grandma. Thank you.
My name is Delia Martinez, and I am an advocate for grandparents raising grandkids. I have been in this group for 10 years off and on. When I got custody of my kids, we had, my husband and I were working on retiring, and we were trying to fix up the house and do what we could so we could retire. We had gotten rid of everything in the house except for the stove, the refrigerator, and our bedroom. And then a week later, we got a call and we got the kids, and we got the baby was 6 months old, the other was 1.5 years, and the other was 2.5. And my husband and I were both working, so this was very hard. My husband, we were gonna go on vacation. He took his 2 weeks, but stayed home to babysit while I continued to work and find daycare for them. We found daycare, but it was still hard because you have to get up in the morning. And at this time in my life, I had no idea this is what I was going to be doing, raising another family again. I had 2 sons and 1 daughter, and again, I have 2 sons and 1 daughter that I'm raising. Sometimes I forget and I call the other one Cindy, and her name is Evelyn, and it's like deja vu. I feel like I'm doing the same thing over again. But anyway, the kids have been having a hard time. They've gone, I thought maybe because they were so little, they wouldn't have any emotional problems, because like the baby was 6 months old, she wouldn't have any problems because she never knew her parents. But I was really mistaken, because they all have emotional problems. Evelyn, now that she's in school, she started questioning, okay, where's my mother? Why isn't my mother around? Weren't we good enough for my mother? Why did she have to leave us? And it's hard to explain to them. And she says, they ask me, what do you and your mother do? She says, I don't know what to tell them because I don't know my mother. I told them, you tell them, I am your mother, and this is what we do together. So what they do together, they help us. Both Mercedes and my kids do what we do. They go to all the fundraisers and things that we do. We take our kids and they participate, they help. So they're learning also to advocate, they're learning to help, they're learning to volunteer, they're learning all these things. My son, the oldest, is now there's 2 in high school. One's a freshman, the other one's a sophomore. Evelyn's in the 7th grade, and they all want to help, they all want to be part of this. My son, the oldest, said, Grandma, why you have so many issues and stuff with the grandparents that you're working with, and you all have different concerns? Why can't I have a group, that support group for the kids that are getting raised by grandparents? Because we have different issues. I said, why not? Start working on it. Find a name for your organization, for your support group. Do your mission statement that you want to do. Find out who were the people that you would invite to come and talk to you. So he's been writing that. He wrote an essay at school this past summer, and he won, and he got a trip to the Washington State Leadership Conference. And that's what he wrote about doing a nonprofit, about doing a support group for the grandkids that are being raised. Okay. We did a resource fair in May, and we found out the concerns that we have for the grandparents. The concerns were financial, legal, food insecurity, available and safe housing, furniture for grandchildren, which is beds, because once they get the grandkids, it's like, where are they going to get beds? They end up sleeping on the floor. Transportation, childcare, and also they have a big problem is the language barrier, and then behavior problems with the kids and immigration status. Okay. And one of the things that I decided to do when we found out that legal problems is one of the big concerns that they have. they don't have money to afford to get lawyers. So I thought, okay, what can I do to work on this? So I told my husband, go drop me off at the courthouse, and I'm gonna see how many judges I can talk to. I went and I knocked on Judge Peter Sakai's office, on his door, and I told him, I know I don't have an appointment, but I'd like to speak to him. If I can only have 5 minutes to talk to him. And I think I can do it if I have just talk to him. And I was waiting. When he came in to work, I grabbed him right away and I said, this is what we need, this is who I am, and this is what I'd like for you to get from you. I said, I want to get a meeting where you can have lawyers, you can have the judges from the children's courts, and other people that can help, and let's see what we can do. So he did it. He said, okay, we can do it. Because he sees the problem in the courts. All the judges see the problem. So we got together, we got the lawyers there, the judges, the other people that helped. And then he asked us at the end, okay, what is it you want from us? I said, I want a legal task force that's gonna help grandparents with pro bono or at a reduced rate so they can help them. He said, okay. He told the lawyers, okay, you all get started, start calling, and thought, oh my God, we did it. We got it. So we took our first 10 people, grandparents, to go talk to the lawyers, do the intake, and get assigned to the lawyers that are gonna help them. But that's still not enough. You know, this is just one thing that we have accomplished, and we're very proud of that. But there's so many other things that we need to do. And we still need people to help with this, with the legal problem. We need more of the lawyers and people that can help with this.
We also asked for the judges to maybe even consider doing town hall meetings with other legal leaders in the community to hear grandparents' concerns regarding this issue. We've also, Delia and I have gone to Senator Menendez's office and knocked on his door and asked him, how can legislation be changed? How can policies be changed? You know, foster care gets quite a bit of money for fostering children. Why can't that money be somehow channeled for grandparents? When we have grandparents, I have one grandmother, 83 years old, with 7 grandchildren under the age of 10. And so how can she actually function and do all the things without the proper transportation, without proper finances to provide for these children? The mother's incarcerated, the father is illegal, and he can't, he doesn't support his children. So we've asked Senator Menendez, and we also have working on an appointment on other public officials to be able to hear our voice. That, you know, there's a gap here. There's programs for senior citizens and there's programs for children, but where is the programs for the grandparents that are raising? We don't fit in. We don't fit in. We can't go to an exercise class and take a 3-month-old or 5-month-old, or have to pay for babysitters and all that. So there needs to be an adjustment here. There needs to be a focus on what is it that we can help these grandparents. Delia and I already adopted our kids. We're already retired. We're already okay in the financial area, that we have our kids in some sports and some music and some activities. But what about those grandparents that are not able to, you know, that have to take the bus with their grandparents, have to take 3 buses to go get diapers for that grandchild that they got, because it wasn't a CPS case, and it wasn't, they don't have support, and they don't have financial. So we're asking the public officials to step up and look at policy. We're talking to Centers with Policies and Procedures and looking at how TANF can make a difference. You know, right now I think it's $95 here in Texas. You know, Louisiana has a policy of it's $220-something there. So, you know, looking at all those things of how things can change for grandparents to be able to support these children that by no fault of theirs are there. You know, and so we've gone to a lot of presentations and luncheons, and they talk about 2-parent households, and they talk about, you know, but grandparents are not talked to or addressed. I've talked to Dr. Woods about going into the schools. We have that one support room at Broccoli Elementary School, and I've talked to Dr. Woods that, you know, we need to identify more grandparents to be able to give them. I know Learning Tree is here. That was one of my biggest things, childcare after I got the kids. You know, what do I do with them if I have to work? I had to change 3 childcares for their 6-year-old, and I had to change them in 3 different childcares in 1 year. I didn't know Learning Tree was available after school. When I registered the kids in school, they didn't give me a resource list that they could say, you know, this is available for you. And that's what my goal was, you know, when Billy and I talked, how can we make awareness so when the grandparent comes and brings a court order or whatever to the school, that the school can actually identify that child and give that grandparent support and guide them to us or to us, to a support group that we can say you're not alone. If there's anything we can do to help you, we're there. So we're asking you as a community and Delia will do the presentation on asking how you can help us support this.
So I have been on the ground floor listening to the grandparents' stories and what they are going through. I see the faces of both the grandparents and the grandchildren, the desperation, the sadness, the fear, and the helplessness that they feel. So this is what inspired and motivated me to be an advocate and to be here on their behalf. I feel an urgency to do something about the problem now. I read the newspaper every day, and I see reports on CPS, what's happening with them, on foster care, and on children dying. So I feel we need to do something now. I read our community leaders are saying the community needs to step up and come together to help. But we need the community leaders, the nonprofits, the companies, the different organizations to step up and to help too. I guess this is like a war. When there's a war, the leaders get their best people, their equipment together and see what and how to fight the war. Well, this is a war. It's a war against drugs, abuse, neglect, poverty, children dying, and due to all these things happening in their lives. These are all families that are at risk. You are the best people. You are here because you care. You have your nonprofits, your companies, and your organizations, so find out how you can help, and so let's step up and fight this war together. You have whatever organization or company or whatever you have, look and see how can I help? What can I do? If you're a counselor in school, check and see how many kids do I have here that are being raised by grandparents, and then do something, help them. And what our vision is and what we're working for is to have sort of a one-stop center where a grandparent is having problems, they can come and we can direct them. We have this organization, this helps you for this, this helps you for the other. And this is what we're working towards to get, because it's very hard for the grandparents to go anywhere, to travel and get information, and there's a language barrier. So it's very hard for them to do this. So, and I think you know that God works in mysterious ways, and He gives everybody a purpose in life. I have found mine, and I think she has too. And I think you have found yours because you're here and you care about the children. So let's see what we can do to help. Thank you.
One of the things we're going to talk a lot about in the coming moments is social determinants. And it can be a very sterile term. And so I want to thank Ms. Bristol and Ms. Martinez for giving us a very vivid and eloquent example of exactly what we mean when we talk about social determinants. Really the most critical social determinants are the ones that affect developing children and have ripple effects across the life cycle. And here's an example where not only do we have that effect on kids, but people at a very different stage of their life cycle and how it affects those families in such potent ways. So let's thank them one more time for their courage and for their advocacy. All right, it's time for us to jump into the presentation of the Community Health Needs Assessment. And I'm going to invite Dr. Steve Blanchard from Our Lady of the Lake University to come up and start us off. And Neil Mangla, who's an epidemiologist at Metro Health, is also going to join us. And we're going to have at it on the assessment for a few minutes. Thank you.
Sorry, but I can't see that from here. See where we are. I'm gonna get myself. Oh, that's the first movie. Thank you for that. Good morning, and thank you, Bob. I'm the first of three to provide the review of this year's Community Health Needs Assessment. Bob Ferrer, the board chair, and a member of the faculty at UTESCA, the Department of Family and Community Medicine. And Dr. Neil Mangla, who's the epidemiologist at Metro, will follow with something a little more detail.
Can you speak closer to the microphone?
Sure. And I'm going to give you a more macro look. One of the things that you'll see, if those of you who've been before, this is the Community Health Needs Assessment, whereas before we've called it the Community Health Assessment. So that is an indication of our direction that we're going this year and recommending to the community. And we'll speak more about that as we move through the morning and looking at issues of equity. I want to go back and also thank Ms. Briscoe and Ms. Martinez. Really, when we do, I'm a data person too, but the CHNA, which we call it now, is the heart of that, is the voice. It's the conversations we have with members of the community out in the neighborhoods and in focus groups and key informants. That's really what this is all about. And it gives life and heart to the CHNA in ways that I could never do, standing up here and showing you slides and tables. But it was a good introduction to kind of get us alive and open our hearts to what we see when we see the data, because these data are us. They are descriptors of who we are in our community. So it's important we take a look, and especially when we look at the issues of disparity and issues of equity. On that first slide, there are guidance principles for reading the CHNA. Those of you who have seen the CHAs before, the previous reports, this is very differently organized. It is organized in a way that it focuses first, it tells you what makes us healthy. And then the chapters themselves, as you go through it, take you from contextual, social built environment issues to health-related behavioral issues to farther down health population health outcome issues. And then it concludes with implications for action, which is really kind of a web that will take us into the Community Health Improvement Plan that will be the action that we will take as a community in response to the things that we see in the CHNA. One of the things you'll see in this report that's different than past, we are focusing on our geography of zip codes. We're doing this for a couple of reasons. There's a national discussion now out there. Sociologists and field epidemiologists have known this for 100 years. But it's becoming more prominent, and that is that place makes a difference in terms of population health. If you know something about a neighborhood where somebody lives, you can get a pretty good idea of their lifestyle and the consequence of that lifestyle and their health, to their health. So in line with the national discussion, we have framed a lot of our geography in terms of zip codes, and you'll see that in the maps that I'll present here in a few minutes. The other reason why we did zips was at the 2013 rollout, a gentleman stood up during question and answer and said, you know, your sectors are cool, but I don't know what my sector is. And he said, you should use a geography that's more familiar to us. And as members of the community, well, nobody knows their, a lot of those geographies, but they do know the zip. And so we thought that it would be better to do zip, stay in line with the discussion nationally, and also to give a meaningful geography to the members of the community. Sorry, I have to keep putting my glasses back on. One of the ways that we want to think about the CHNAs is, as we've talked about before, is population health diagnostic. You might consider the CHNA is to population health, because we were population diagnosticians, all of us in this room. We are concerned about individual level health, but we're really interested in the dynamics of population health. So you might consider the CHNA is to population health what the blood draw, if I may say it that way, is to your physical health every year for your primary care physician. The blood draw is a way for your physician to get a good analytical view of the physiology of your health. The CHNA does the same sort of thing for population health. It gives us an analytical view of the status of population health in Barrett County. The upstream perspective, we had talked about this once before, I think in 2013, but let me speak to it again. It comes from an old African parable, and that is that 3 people came across a raging river with children being washed downstream and over the abyss. And the 3 people jumped in the river and they were looking for ways to try and save all those children, but it was futile. I mean, they could save some, but they couldn't save all. And so one began swimming upstream, and her 2 colleagues said, well, where are you going? We have children to save. And she said, I'm swimming upstream to see who or what is throwing these children into the water. And I think that is a good descriptor of what we're doing here. A lot of what we do with the CHNA is downstream, but we're really looking at upstream factors that produce those somewhat downstream health-related behaviors and farther downstream health outcomes. Now, one thing that we've included this year that has always been in the background are confidence intervals. And when you read the report, you'll see a lot of the data are expressed that way. The data where you see those confidence intervals are sample data. They are from the Behavior Risk Factor Survey, a CDC telephone survey, and the zip codes. So where the confidence intervals are peaked, then you get a pretty good, precise estimate of the value of that particular data element in that neighborhood. Where you see the confidence intervals flattened, that means the sample size is not very large, and that estimate that you see for that particular zip code is not as precise. So I mention this for 2 reasons. One is as we move to 2019, we're always moving forward with this, we have to consider whether we want a larger sample in order to get more precise estimates or work a better way with extant data. The other thing that's important, at the data committee, one of our colleagues, Pilar Oates, made a comment that the flatter those confidence intervals are, that's an indication of the risk of silent voices. So where those confidence intervals are lower, there are fewer people who are participating and a higher number of silent voices in those neighborhoods, something we want to be sure to correct. The last thing on this, I think I can do this without looking, but I better look anyway. Social determinants of equity. We have moved over time in our assessments from social determinants of health over the last assessment or 2 to social determinants of disparity. But we're recommending to the community, as many of us in the community are already there, in terms of looking at social determinants of equity. We want to be more in terms of resolution of the issues we see in front, not just simply describe the disparities, but what can we do about these disparities? Okay. One of the things, many of you will know what these are, so I want to speak to this for a second, is looking at a logic model in terms of plans of action for what we do with the data. This particular logic model is an upstream, middle stream, downstream logic model. And the far right-hand side, we might say, as Judge Wolf spoke to, the staggering difference that we see in life expectancy or premature death, south side relative to north. So maybe our logic model, if that would be our outcome of interest 20 years downstream, or down to make that more equitable, there may be activities that we can do that could be framed in terms of the logic model. For example, we might look at the issue of uninsured, a policy issue, trying to promote greater access to what is popularly or unpopularly known, depending on your political perspective, Obamacare, which is really the Health Reform Act, more enrollment in that, or improving the walkability in neighborhoods so people with cardiovascular disease can exercise, and that sort of thing. Or if we're looking at behaviors, we can look at HIV, how we can address issues of HIV in order to prevent AIDS. Or we might look at down in terms of other issues of behaviors, improving bicycle paths. There are a lot of bicycle paths in the city. There could be more. It's our bicycle death rate is not that high, but it's there are more and more people getting on the streets. And then the downstream, far downstream, would be premature death. We want to raise premature death. We want to raise the life expectancy so that premature death is not so dramatically different from one area of the county to another. So the logic model, each one of those activities would be something that would improve life expectancy, so that a far long downstream outcome of premature death, we could minimize that. I wanted to give you a comparison with where we are in relation to, in Barrett County, in relation to the rest of the state. The county health model that you see up here out of Wisconsin and funded by Robert Wood Johnson, I don't know that it still is, but it was initially, is a way of looking at social determinants or factors, upstream factors, middle stream factors, and downstream factors on health outcomes. And you'll see the diagram on the left, and it's also in the Chenal. But I wanted to point out that for Barrett County, in health outcomes, we ranked 74 out of the 237 counties, if I got the number of counties correct. 68 or 66 in terms of 68 length of life, 125 in quality of life. Clinical care is ranked 15th. Health behaviors, 63. Social and behavioral factors, 128. Physical environment, 48. So compared with our brother and sister counties out there, we're not doing quite so well as we think. So there's work to be done. You'll find that report in the Chenal. I am a demographer and I like population pyramids because I think they're very descriptive. They tell us a story about where we're going to be, where we are now, but where we'll be, say, in 20 years. This particular one is non-Hispanic white, and you can see that it's beginning to rectangularize. Population pyramids, if you're familiar with them, look like a pyramid. They're shaped like a pyramid because of the mortality experience of the population. The greater the mortality experience, the more the side of that rectangle is eroded into a pyramid. If the mortality experience is minimized, then those who die live to an old age, and so the pyramid becomes a rectangle. You can see that ours is becoming a rectangle in terms of our here in the city, in the county, non-Hispanic white. This is the Hispanic white, and you can see that it is a much broader one. Fertility is a little higher. You can see the erosion remains in the upper ages, age groups, but you can see it's beginning to rectangularize, but with a broader base, which indicates fertility. One of the interesting stories about this is that as it rectangularizes, very likely in another 2 or 3 generations, we'll have roughly equivalent number of older population than younger population. So we'll be balanced in that sense. We'll change the way we look at the community, the way we look as a community, and the kinds of resources that we will need. Here you can see that on this diagram, these are all in the Chenal, that by 2040 our population will double. Think about that. And the implication of what that means. And then here you can see that we will be, in a way, a geriatric society in some way. Our elder population is increasing substantially, so there'll be a need for geriatric medicine and services for persons over the age of 85 or over 65. And I expect a lot of those individuals hopefully will have an active life expectancy, and you'll see a lot of us out in the street. All right, so let's talk a minute about life expectancy and the drama of it, the staggeringness of it, as Dr. Laura McCurran mentioned in the report. Here is the life expectancy map. And when you look at this, we could say we could do a story of 2 zip codes. One in the center of the city where it's about 70, average life expectancy is 70 years. Life expectancy is the average number of years a population will live, so that half of it will die before that 70th year, the other half will die in years following that. We could do a zip code story, but I think when you look at this, Barrett County has been and continues to be a story of 2 counties and 2 cities. We've got the south side and we've got the north side. We've got Hildebrand, in a way, and it has for years, been kind of the east-west dividing line. So, and you can see how that is. You can see the gradient of life expectancy increasing as you go north. Now, this report, just to kind of put things in context, this report put together by Robert Ferrer, Dr. Ferrer, San Antonio area life expectancy in national context. Now, what you'll see in that, this is what life expectancy for women, the upper, I forget I think it's the lower 25% and upper 25% of income. I did life expectancy for women because women generally live longer than men, although recent years not by as much. But here you see that there is a disparity between the upper quartile and the lower quartile. And then you also see by that vertical line towards the end where we are in relation to the other 100 some odd commuting zones in the country. Commuting zones are those, if you like, we're a commuting zone because there are people that drive in here, let's say, from contiguous counties. So we don't rank quite so high as we might think in terms of that. And not only that, Dr. Ferrer discovered in his masterful way in doing his research and putting data together that on another source of information, that out of the 100 largest counties in the United States, Bexar County ranks 95 out of 100 in terms of overall life expectancy. That's not good. I'm sure we all realize that. We're here alive, we want to live for as long as we can, and there are determinants out there that are influencing our not being able to do that. Right, so I want to take you on a quick trip up and down this life expectancy. Here is life expectancy. These next ones will have two maps. On the left is the original life expectancy map. The one on the right are correlates or factors, predictors, however you want to describe it, that are a consequence of that life expectancy. And so that you see on the right, you see a map of the household income. And this is taken out of the report, the Residential Segregation Index. Came out in the San Antonio newspaper about a year ago, that out of the 30 largest metropolitan areas, we rank the highest, number one, for residential segregation by income. Very clearly manifest in that map. We are now like 68 in that RISI scale, that you can see, whereas in 1980 we were like 48, so things are getting worse. Issues that we should address, or will address, I'm sure. The next one is the life expectancy by racial ethnic minority population. You can see that the racial and ethnic groups of our city carry the burden of the lower life expectancy. They're in the southern half, predominantly in the South Bexar County, or below Hildebrand, that carry the burden of the lower life expectancy, or if you will, the premature death. If the life expectancy in a zip code is 80, and they live in a zip code of 60, then their premature death is 20 years. In other words, they died on average 20 years sooner than those in another zip code. In this one, you see that the adults 18 to 64 living in poverty, so that again, the poverty population carries the burden of the lower life expectancy. Perhaps not surprising in terms of socioeconomic status. Lower income often means a consequence of a no job or blue collar work, maybe not with insurance, and lower levels of education. Probably the one that's most tragic, in a way, is the children living in poverty. As Dr. Ferrer mentioned, there's an incredibly tragic consequence of health over the life course of a child born in poverty. The stage or the setting or the ground for how they will be in their health for the next 60, 70 years of their life is set in that first, even in that first year of life, but certainly in the first 5 or 6 years of life. I'm sorry, I have to fumble around with this. Here is a time period of housing construction, older houses in the inner city, lead poisoning, other sorts of issues related to living in housing that may not be in the quality that many of us would much prefer to live in. Affordable rental costs. I'm not sure, am I in the right one? Does that say affordable rental costs? Oh, right. Sorry about that. Affordable rental costs, I use this as an index for the contribution people make to their shelter. So if you're living in a neighborhood that's 50 to 60% rental costs, that means you're putting a lot of your income just for residential residents. This one is the uninsured population. Probably doesn't surprise us. Dr. Judge spoke to this. The uninsured. There's some interesting information out now. The Health Reform Act's not been out that long, but it's out long enough now for us to begin to get an idea of the benefits of that. And you'll see there that Obamacare, so I can put it here, as the article says from the New York Times, appears to be making people healthier, less likely to have medical debt, less likely to postpone care because of costs, more likely to have a regular doctor and to be getting preventative care. This is a policy issue, as Judge Wolf spoke about, something that needs to be addressed with the locally in terms of helping people to get more insurance, better insurance through Obamacare. But in that same article, there's a JAMA reference, and we'll appreciate this also because of what the judge said. They had done a study of the Medicaid expansion in Kentucky and Tennessee and compared that with the non-Medicaid expansion of Texas, and found that people in Tennessee and Kentucky under the lower poor income had much better health. So there's evidence that the expanded Medicaid does have positive consequences for health. This is one that adult health literacy. You can imagine that people that are not sure about the physician's regimen can't read the medicine labels, what the consequences that can be for their own health. So associated with a lower life expectancy is low health literacy. And the last one I wanted to mention here is a behavioral related. If you are living in times of stress or a neighborhood of stress, social context, social cohesion is low, often a resort to alcohol as a way to get through the day. And then, of course, the consequences of that for our health. And this is actually the last one. Vacant housing has an implication for social cohesion in a neighborhood. If you live in a neighborhood where you feel good, you can get out in the streets and walk in the evenings and you don't feel threatened. In neighborhoods where there's a lot of vacant housing, that cohesiveness is not there, and it makes at least a sense of the neighborhood being unfree or unsafe, and perhaps even actually unsafe, so people don't get out and walk. And that also is in association with low life expectancy. This one maybe will lead us into discussion over the next several months. These two maps are life expectancy maps. The one on the left has commissioner precincts, so the commissioners can see what the distribution of life expectancy is across the precincts. And the one on the right are the council districts, so that the council members can see the distribution of life expectancy and other issues in this report across their various council districts. Dr. McCarron will speak to this, but at some point when we get to the interactive portal, you'll be able to go up to Chenal and add the boundaries that you choose on the map of interest to you. So, thank you very much.
Okay, good morning, everybody. Morning. If you were bored with this data, you're going to see a little more data. But I promise you, I'm going to kind of put it in a story form. So it won't be just data and numbers, it will give you a story behind those numbers. Before I start, I want to actually thank Elizabeth Lutz for all her leadership at the collaborative. Without her, I don't think we'd be this far. I also want to thank the data committee members. We have spent hours and hours kind of generating this data. There was a lot of disagreements. There was a lot of areas where we agreed. There were consensus. But the most important thing that we have in this team of ours is teamwork. We, at the end of the day, make our decisions and we stand behind that. Let me start by saying I applaud the parenting, grandparents as well on being aggressive. And when we're looking at our healthcare system, when we're looking at the burden of disease here in Bear County, we need to start being much more aggressive than we have been. And I'll kind of give you an example about that. So the first slide I have, and this is kind of difficult, is kind of giving you the leading causes of death in Bear County. And as you can see, it's not any different from other major cities. And we also have compared that to the state of Texas as well as the United States. Then I have one where it's leading causes of death for under 65, and you'll see the diseases change. And so again, this is something we want to prevent, because when we look at longevity, we want to make sure people are reaching the high 70s, mid 70s, what their demographics show. So there's a lot of diseases we have here, but and sometimes when you look at this, it's depressing. But what I want to talk about is some success stories, and the success stories come by where you work collaboratively with many other organizations. Now, if you look at that graph, it will kind of tell you very clearly that when you're looking at social determinants, when you look at just a person's health clinically, it's 20% is going to help the individual. But when you look at social determinants, there's a lot of other factors that influence a person's health. And that's the direction we want to go, because a very good example, and you just go to a dialysis center, for example, and you will see a parent maybe in kidney failure, but the parent also has amputations. When you start searching and you're going, as Steve was saying, upstream, when you look at upstream, you'll see that there's other family members that are affected. And so again, that environment where you live plays a vital role in your health and your ability to, take care of your family with a variety of diseases. So Steve brought up a very good graph on population. So I have the population here. This is Bear County, 2004, and I kind of marked the current age group, which is the 25 to 34. And I have an arrow going up 30 years, and the reason behind it is that is the population that are going to be the ones where we want to focus on. But there's no point focusing on the population now. We need to focus on the populations that are in the 30s and in the 20s to make sure, again, looking at upstream, that these individuals are educated, they know about disease, and they can look after themselves. So by the time they reach 50s and 60s, we won't have that much of a burden. And I bring this up because I have a slide that really shows where we should be focusing when it comes to diabetes. So we've had success stories, as I said. Thank you to Dr. Schlenker, who came here 5 years ago and identified that we had a major syphilis issue here in Bear County. But we also had a congenital syphilis issue. And what we did is, again, we cannot do this on our own as a health department. And so we started looking at organizations within the community that could actually assist We went to hospitals that were one of the major organizations that we worked with. And as you can see, over the past 4 years, our numbers had decreased substantially. So we're moving in the right direction. Again, this really takes a lot of effort, but it takes community involvement. Another really good and success story is the congenital syphilis. And as you can see, when Dr. Schlenker came to the health department, we had a large amount of cases, 2011, 2012. Those numbers have now significantly decreased, well, almost 48, 49%. This year, we're on our 6th congenital case. So again, numbers are going down, and it's a very positive, outlook when you look at how you can work with the community to make some effect where we can decrease the amount of burden. So now let's go to diabetes and obesity. And as you can see, we only see part of the crisis that we face here in Bear County. We have a lot of people that are obese, and as you know, obesity then causes individuals to be diabetics. You can see the numbers where they are pre-diabetics. It's kind of difficult to see, but it's giving you a pretty good idea where we stand. This is a very interesting graph, and sometimes we look at just numbers, but as you can see, the amount of amputation rates here we have in Bear County. So Bear County ranks almost number 1 when it comes to the state of Texas about these amputations. So what are we doing and how are we doing it? So this is a very interesting graph, and I go to so it's giving you an idea of A1C. And the A1C is, if we change A1C by just 1 unit percent, in 20 years you can see the difference that will cause in Bear County. This is Bear County numbers. So again, significant changes just by decreasing individuals' A1C by 1%. But more important is, we're going to look at our legislators. And if you look at that 1% change in A1C, within 20 years, look at the amount of savings we'll have here in Bear County, almost $400 million. So these are big numbers, and this is something that can be doable, and that's what we need to achieve when we're looking at burden of disease. This is another important graph, also again related to data that is local data. And again, if we look at people changing their lifestyle, and if you look at that change in lifestyle, all they got to do is change their diet and exercise. And you can see the significant changes. Although the percentages look small, when you convert those to numbers, those numbers are very high and will make a significant difference here in Bear County. On that note, I want to also bring up that this is, so when Dr. Schlenker a year ago actually started what's called the Diabetes Collaborative. The Diabetes Collaborative is something that is going to work only if we have people in the community, community members, community organizations that have the same goal. And the same goal is to make sure that we can decrease diabetes here in Bear County. So this is for me a call to anybody here in any organization that is doing diabetes work to contact Jennifer Harriet at the health department and get on a list to be part of this collaborative, because at the end of the day, what we want is we want to make sure that we all have our goals, but unanimously we have one goal, and that could be to decrease the A1C. Now think of those numbers I gave you, right? You look at in 20 years, we're going to save $403 million. And let's look at upstream. So for every month we're not doing anything as a collaborative, we actually using $1.7 million, and that's just gone, with no savings. So again, this is again a call for any of these organizations that are doing work in diabetes. Please call Metro Health, get on a list, and let's start working together as a collaborative and make some burden in these diseases, because we need to be very strong and very aggressive when it comes to diabetes. And on that note, I'll kind of stop. Thank you.
All right, so I'm going to wrap up this segment trio of talks with saying a few words about a potential way forward in response to the data we've been looking at. And I think there's 4 points I want to make. So one is to understand where health comes from. And because to have the right treatment, you need the correct diagnosis. So when we think about what actually determines the health outcomes for the people in our community and our society, we need to make sure we're looking in the right place. And often that place that we look for health improvements is the healthcare system, which is incredibly important, and it's also a very high angst proposition in a community where so many people lack access to healthcare, right? If you're sick and you don't have healthcare access, as so many in our community don't, then that seems to be the most terrible thing to you, because you're feeling the burden of illness and you don't see a way forward. You don't see a way to get that urgent help that you need. But upstream from getting sick are all the factors we've been talking about that determine whether you're going to end up ill and need to see a physician or another form of healthcare in the first place. And so we need to make sure that the conversation is big enough to include all the determinants of health, not just what happens to you when you're sick. And so that's what we're focusing on here. A key message is that we need to broaden accountability. The points that we've been making, and I hope to expand upon just a little bit here, is that health is really, because we're human beings and we create the conditions for our own health, health depends on society and culture and all our technical advances. And if we're going to think about health properly, we need to think of it really as a failure of our social conditions. That's where the roots of health lie. I'll show you some examples of that. And so once we have that accountability, then the next idea is, well, what do we do about it? And as Dr. Mangwan just showed you, we need to invest strategically. If we can reduce the risk factors by just a little bit across our whole population, we can realize tremendous savings that then we can reinvest in even more health improvements. And so that's a snapshot of the way forward. I just want to, Steve already showed you these 2 slides. I just want to make 2 points. We have 2 issues that are evident here. One is we have terrible equity problems, as shown in the zip code maps, and then the different prospects that you see here of our wealthiest 25% of residents and our poorest 25% of residents. But the second thing is that whether you're wealthy or poor in San Antonio, compared to our other 100 sister metro areas in the country, no one's really doing that well. Everyone could stand some improvement in their prospects. And so the most pressing problem, because the differences are so large, is the equity problem. But we have a bigger whole community problem that we also need to address by changing the environmental conditions and sort of the defaults for our health. So we've already looked at these. This is the curve for men. I also want to say that these are static snapshots, but San Antonio's trajectory of improvement over time is also very slow. At the rate we're going, it's going to take 30 years to add 1 year of life expectancy for the men in our community, and about 6 years for 1 year of life expectancy increase. And the best performing communities in the United States for men and women add a year of life expectancy every 4 years. So not only is the snapshot today worse than San Antonio, but our trajectory is also much worse. I just wanted to highlight some of the causes, the diseases that cause our reduction in life expectancy. And I've broken it out here by, again, the wealthiest 25% and the poorest 25%. And I'm showing you these numbers, again, to make the point that, number one, everything is higher in the poor compared to the wealthy. It doesn't matter whether you're talking about heart disease, liver disease, homicide, suicide, accidents. Across the board, in those top 10 causes, everything is higher. And again, though, it's about community. We're all in it together. The list is very similar from the wealthiest and the poorest. It's not that the poorest people are dying at higher rates because they're dying of special things that don't affect the wealthy. They're the same things. They're just more common. So if we address the most important causes of death and illness in our society, we're going to lift everybody up. And again, we hope to lift up the people at the bottom of the income ladder the most because they need it the most, but we could all use some lifting up. And so we're all in it together. So I'm a primary care physician. I've been practicing in this community for 19 years, and this is why I'm standing up here with the Health Collaborative. This is what motivated me to get involved. The x-rays that you see here are from 4 men in our hospital service at a university health system. We're primary care doctors. These people are admitted by the podiatrist for amputations, which Dr. Mango showed you. We're in a community with a very high rate of amputations. Our job as the medical doctors is to stabilize them before their surgery, so we treat their gangrene, their blood infections, their sky-high blood sugars. We try and fix the renal failure that they often have when they come in. And so we have them a couple days usually before their surgery. And I can't tell you what it's like to take care of them. They know what's going to happen to them. They can see the future. They can start to see their future. And they're already, in those 2 days, the sense of loss, the mourning, for what's going to happen to their body, but also what's going to happen to their lives. These are men who largely work in manual labor. A lot of them don't have health insurance, which is one of the reasons they got to this point. But this last year, with the help of Tom Schlenker and the folks at Interlex, we decided to convene a group so we could really try to understand how the men got to this point. It's not just a matter of taking their medical history. We wanted to understand, how did you come to get so far along in your trajectory with diabetes that you're losing your foot or a toe, or in some cases the lower leg. And what they basically told us was, I worked. Most people who work in jobs like that work very hard for minimal rewards, and they prioritize putting food on the table, being the caregivers for a family, more than their own health. And so at every stage of their illness, that was their priority. It wasn't looking after themselves, it was being the providers for their families. And the irony, of course, is that because they work in manual labor, this operation is going to put an end to their working life, at least anything that they had before. And so it's a very intense time for them. And it's an intense time for us as the caregivers because we're trying to alleviate their suffering and to find a way forward for them. But these are the stakes. Underneath all the statistics, the stories that you heard from our grandmothers this morning, and the stories that we see as physicians, the people who get to us as a result of all the social factors that we talked about, these are the stakes that we're talking about. So this is about something we call embodiment, how the social conditions in the society, they literally get written into our bodies in terms of missing toes or clogged arteries or sky-high blood sugars or failing kidneys. We need to think about illness as sort of the final pathway of adverse social conditions. And you see them listed here, problems with education, employment, income, housing. I won't read them all to you. But these aren't just health statistics, okay? They're measures of our civic performance. We need to think about them that way. Our leaders, our organizations, our employers, all the people that care about San Antonio's civic performance need to think about these life expectancy statistics, these morbidity and mortality statistics, as measures of how we're doing as a city in the deepest way, together, as a community, and not just about health. This is another we're all in it together slide. This is the curves of what's happened with the obesity body mass index measure over the 30 years of the obesity epidemic. And you can see that it's not just we think about personal responsibility and making good choices and so on, but these curves show us that it's not just a few people at the high end that have let themselves go, making poor choices, gluttony, become obese. That's not what it's all about. This curve shows that our entire distribution of body mass index has moved. The skinny people are less skinny. The average people are now overweight. The overweight people are now obese, and the obese people got really obese. This is a whole community problem that has to do with the default behaviors in the United States. These are national statistics. And it's not just about changing people one at a time, it's about changing our way of life and what we prioritize and how we invest and what's normal. These are also national statistics looking at 4 healthy statuses: being a non-smoker, getting enough exercise, having a healthy diet, and maintaining a normal body weight. And you can see there's a group of outliers in the United States that go against the grain of society. And those are the people that do all those 4 things right. 2.7% of us. Right? So what's normal? Normal is unhealthy for almost the whole society. And we've got to think about what we do in that way. In my clinic, we think about healthcare as being part of this, and it is an important part, but it's, in terms of population health and things like obesity, it's not anywhere close to being the answer. I did a survey a couple of years ago in my clinic. We asked 300 patients with either obesity and diabetes to see whether their doctors were doing the right thing and talking to them about physical activity and exercise. And almost all of them said yes. So kudos to us. We're doing great on that. We're telling them what they should be doing. But then I asked them another question, a follow-up question, and I said, does your doctor understand how hard it is for you to eat right? Again, I work at the Robert B. Green Clinic. It's people from the zip codes with shaded in the unfavorable colors on the maps we just showed you. So it's a poor population, very high morbidity. And half of them said the doctor doesn't understand how hard it is for me to be physically active because I live in a neighborhood where it's hard even to go out for a walk after dinner. And 2/3 of them said the doctor doesn't understand how hard it is for me to eat right. And in that same survey, we looked at people's ability to buy food, and 70% of the patients in my clinic run out of money for food every month. And these are some of the other opportunities, barriers that people face. A lot of people said they have fruits and vegetables where they shop, but then, more of them, about a quarter, say they don't seem to be of high quality. 15% say it's not so easy to get to the food store in the first place. We lose almost half who can say they can afford meat and fish. And we lose 3/4 who feel safe walking in their neighborhood after dark. So these are structural barriers that make it hard for people to do the things that we're always exhorting them to do, often without knowing what's underneath their actual experience. So this is a simplified model of sort of our task in front of us, right? At the very bottom, at the very last stage of this pathway, we have the outcomes, the early deaths, the diseases, the diabetes, the high blood pressure, the heart attacks, the cirrhosis. And where we spend a lot of time as healthcare providers, as communities, is in telling people they need to make healthier choices. But we don't think about what comes before that, right? The choices you make depend on the choices you have. There's an opportunity landscape that people face. Affluent people have a better opportunity landscape. Less affluent people have a less favorable opportunity landscape. But the choices come from that landscape. What's available, what's affordable, what's convenient in the place they live. And so what structures the opportunities are the resources that are available in a community. Is there a grocery store with good-looking produce that you can afford to go to? And it's people's own personal resources. What's their income? What's their social support to be able to do the things that we're asking them to? So really, when we think about a way forward, there's 2 blocks. There's the public health block, which is helping people to behave better to get them to stop smoking, to encourage physical activity, to create landscapes on which people can be active, to have a better food environment, to reduce the risk of sexually transmitted diseases, all the things that public health does, the essential things that public health does every day, and most of which is woefully underfunded in the United States. But the second block that often we don't talk about as a health problem is community development. So all these problems, as I showed you before, from top to bottom, all the diseases are more common in less affluent people. And so what's the way to make healthier people? To make people who are better educated, more affluent, and you cure 15, not cure, but you reduce the chances of 15 or 20 diseases all at once, almost by magic, by giving someone a good education and a living wage and a decent income. So this is just an example. This is the chances over the last 35 years of developing diabetes by different levels of education. People who don't graduate from high school or go beyond a high school education. And you can see the differences. The payoff from education is getting bigger over time. All right, everyone got obese in the United States, and so all of these different educational categories have a higher risk of diabetes. But the gap between the less educated and the better educated is growing over time, just like the gap between the less affluent and the more affluent is growing over time. So we need to think about a community engagement strategy as a way of lifting people up where they live, in addition to all the public health interventions that we might make. When I started my career in medicine, I came across this quote, this question: how far should you help a patient accept the conditions which are least as unjust and wrong as the patient is sick? And so my decision was not so far, and that's why I'm up here today talking to you, and that's why I'm involved in the Health Collaborative to the extent that I am. And I think we need to think about those conditions very deeply as a community. So again, the way forward, we need to change the narrative on health. We create health through social interventions more than we create health through healthcare. We remedy health with healthcare, but we don't create health with healthcare. Health is a political choice. I'm glad Judge Wolf acknowledged that in his remarks. But when we allocate resources, those are political and policy choices, and we can create less or more healthy policy choices. That needs to be baked into health policy choices across the board, not just about hospital or insurance policy, but about housing, about built environment, about our food systems. It needs to be baked into all those things if we're going to see progress. We need to think in terms of opportunities, accessible opportunities for everyone as a way forward. And we need to invest in public health and community development. And at the Health Collaborative, we're actively working on that. If you stay tuned, there will be more to come in the coming months on that very issue. And so I'm gonna leave you with that and hand off to our team that's going to close it out, which is Pilar Oates and Terry De La Haya. And oh, I'm sorry, I got ahead of myself, so I apologize. Laura McKieran is going to say something very important from CI Now. Laura's been the engine behind assembling all the data and packaging it in a way that's accessible to you. And she's going to give you some ideas about how to use the report effectively. And sorry, Laura, I almost skipped you. Thank you.
I thought I was going to get away with that for a minute. I'm looking to assess your level of glaze over, the weighted average of your slouch degree, and how much you're gazing longingly at coffee. And inexplicably, I'm going to try to wake you up by talking about technology. But let's give it a go. I'm Laura McKieran again. I'm Director of Community Information Now, or CNOW, and we are a local data intermediary, and which means nothing to anyone, but I persist in calling it that in the hopes that someday it will catch on. Good information, good data makes for better decisions and better actions, and our team's job at CNOW is to get that good data and information into the hands of folks like you who are boots on the ground working to improve people's lives. I won't go in the right direction. Oh, I did. So what I'm going to talk to you about today is another next step growth in the assessment process over time. The Health Collaborative has always been out in front across the country. Some folks might not know that. In the kind of assessment work that they do. And this year we are adding on a portal, an interactive data visualization portal to help make this data available to you in a way that's useful to you and can help you do the work that you are doing, whether that's planning, monitoring your progress in the neighborhood you're working in, grant writing. Some of you may have been at the CHIP release of the CHIP event a couple of years ago when we talked about a CHIP dashboard. This is different from that. That dashboard is still in the works, and that will be focused on monitoring our progress on the CHIP objectives. Hopefully you'll get involved in that work. But in the meantime, this is intended as a complement to the assessment. It's not a complete reproduction of all the data that's in the assessment. If you look at the long document, there are things that are in that document that you won't find in the portal because maybe we only have a county level estimate for 1 year, and the point of the portal is to be able to break out data by geography, by race, ethnicity, age group, that kind of thing. And then by the same token, we couldn't map everything that we had by some sub-county geography or break out into a bar chart everything that we had by race, ethnicity in that paper document. So there's going to be a lot more that's in the portal that wasn't in the assessment. I am all about expectations management. Life goes better for me when I do that. So let me tell you a couple of limitations that the portal's gonna have. First of all, it's not gonna have all the indicators that you want. Our experience as a data shop has been that if we provide 547 different pieces of information, somebody needs number 548, and we have to go and find that. So we're going to start with the data that we have and build on it over time, but please do, when you use it, expect that there's going to be a lot that you're interested in that's not yet available. Similarly, we're not going to have all the breakdowns that folks would like. Maybe we'll have the data broken out by some demographic variable, but not by zip code or any other sub-county geography. We probably will not have any record level data. So any of you who are hoping to do some kind of robust statistical analysis through this portal, this isn't for that. We definitely will not have any identified data to protect folks' privacy. This will all be either non-private data or aggregated, grouped by geography or some other variable to protect privacy. We expect that some users are going to need training and support. We will be putting together videos and also in-person trainings and assistance to help users get good at using the tool. And then, of course, wouldn't it be cool if we had the ability to update this data over time instead of having brand new data once every few years? But our ability to keep it updated is going to depend on resources that are available to do that. And of course, we can't add in data sets that we don't have permissions to share. So those are some of the limitations. But the intent of the portal, having disappointed you up front, show you some cool stuff, is to allow you to visually explore the data. And as you can see in the presentations today, which for some reason have rendered all of our colors kind of light turquoise and